Okay, Commander Kenji. In this module, we will be going over the pelvis, chapter 8. The pelvis provides structural support for the body and encloses the male and female reproductive organs. Because of its role as a support mechanism for the body, the pelvis has a large amount of musculoskeletal anatomy. So we will be going over a good amount of musculoskeletal anatomy. The sacrum, coccyx, and os coxae. The bony pelvis is formed by the sacrum, coccyx, and two os coxae, or innominate bones. Innominate bones. The lateral mass contains sacral foramina that allows for the passage of sacral nerves. The pubis or pubic bone forms the lower anterior portion of the acetabulum and consists of a body and superior and inferior pubic rami. The ischium, the inferior portion of the os coxae, like the pubis, is composed of a body and two rami. Okay, this is an MRI axial T1 weighted image of the ilium and SI joint or sacroiliac joints. We need to identify the linea alba fiber structure that runs down the midline of the abdomen. The psoas muscles, and the iliac muscles, as well as the sacrum. So we have the iliacus muscle, and actually the psoas and the iliacus muscle come together to form the iliopsoas muscle. And this is the ilium, and here is the sacrum. Coronal T1 weighted MRI image of the sacral iliac joints. Coming down here, coming down there, and this stretches all the way through there. That's the bottom edge of the SI joint. So here we want to identify the sacral mass, the sacrolateral mass, the sacral foramina. So you have the sacrolateral mass, sacral foramina, and the nerves that traverse the foramina, the gluteus medius muscle. You have the gluteus medius muscle up there, and you have the gluteus maximus muscle. The union of the pubic rami and ischium surrounds a large opening termed the obturator foramen, which is enclosed by the obturator muscles. And those are the openings in the pelvis, the circular openings in the pelvis. Here we want to identify the acetabulum, which is that area right there, the iliac crest. The sacrum, coccyx, as well as the ischium. The ischium. Remember, the ischium is the bone that you actually sit on. So you have the ischium that's back there, and the pubic bone is up there, the ilium, and that comprises the bony pelvis. MRI T1 weighted image of the pelvis with pelvic brim. This image can be found on page 500. And here we have the arcuate line. Right there, the arcuate line. That's important to understand simply because they have a condition where the femoral head can go through the arcuate line, and is hip protrusio, but the head of the pelvis is always supposed to stay inferior to the arcuate line. If the bone becomes weak, the head of the femur can protrude through that arcuate line. So the concave anterior surface of the ala is termed the iliac fossa, which is separated from the body by the arcuate line. This arch-shaped line, which is located on the anterior surface of the ilium, forms part of the pelvic brim. So this image can be found on page 501. It's a T1 weighted coronal image of the right hip, and that's an acetabulum. So we would call this region the hip. And here's the acetabulum. So we have the femur and the lesser trochanter and the ilium. The lesser trochanter is an important landmark because it symbolizes where the symphysis pubis will lay, and the bottom portion of what is termed the abdominal cavity. Okay, 3D CT of the pelvis is superior view, so this is what we call a bird's eye view. The pelvis is divided into the false or greater pelvis and the true or lesser pelvis. The region above the brim is called the false pelvis, and the region below the brim is called the true pelvis. The superior aperture or inlet of the true pelvis is measured in the posterior direction from the sacral promontory to the superior margin or crest of the pubic bone. The pelvic outlet or inferior aperture is an opening bounded by the inferior edges of the pelvis and is measured from the tip of the coccyx to the inferior margin of the pubic symphysis in the antero-posterior direction and between the ischial spines in the horizontal direction. I'm actually trying to read this book from a distance, so it's difficult for me to see the words because I'm focused more on the picture, so I do apologize. So here we have an axial T1 weighted MRI of the pelvis with the gluteus muscle group. So the gluteus muscle group would include the minimus, medius, and maximus. All this back here. It's the gluteus muscle group. This is the piriformis muscle, not part of the gluteus muscle. So, and these are the extrapelvic muscles. The rectus abdominis visualized on the anterior surface of the abdomen and pelvis. So that's the rectus abdominis, our six-pack. We love those muscles. The psoas muscles extend along the lateral surface of the lumbar vertebra. That's actually the tenderloins. When you're eating tenderloins, you're eating the psoas muscle. The external and internal oblique muscles are located on the outer lateral portion of the abdomen. Just superior to the inguinal ligament is the inguinal canal. That's pretty much where the spermacord protrudes down and through. As a matter of fact, that's the weak spot in the male's anatomy where the bowel can protrude down into the scrotum, and it's called an inguinal hernia. but just because the testes that rest on top of the kidneys in infancy that migrate to the scrotum during the maturation process leaves a weak spot in the inguinal region, and this is the inguinal canal, and this is also the canal that can become invaginated from bowel. It's called hernia. The largest of this group are the gluteus muscles, maximus, medius, and minimus, which function together to abduct, rotate, and extend the thigh. So the pelvic wall muscles. The muscles of the pelvic wall include the piriformis. Here's the piriformis, right there, which acts to rotate the thigh laterally. Also functioning to rotate the thigh laterally is the obturator internus muscle. Inserting on the greater trochanter, just below the obturator internus muscle, is the obturator externus muscle. So we're not in the area of the greater trochanter, but we know that the greater trochanter is going to operate outside there. So this is an axial T1 weighted MRI of the right hip with the iliopsoas muscle. So this is the convergence iliopsoas muscle. So this is the convergence of the iliacus muscle and the psoas muscle. So remember, the psoas muscle starts lateral to the lumbar vertebra, and now this is the head of the femur. So now we're anterior to the head of the femur. So the psoas muscle attaches to the back and to the head of the femur. If you notice, you do a younger person or an athlete, the psoas muscle is huge. It actually is the muscle that is used to flex the thigh. So in this image right here, we want to make sure that we completely understand the acetabulum, the iliopsoas muscle, as well as the obturator internus muscle. Axial T1 weighted MRI of the male pelvis with the coccygeus muscle. Coccygeus muscle. Right there. You should be able to tell whether this is a male or female just from the spermatic cord. This is the area where the testes burrow down into the scrotum. Females will not have this area. This area is also the weak spot for inguinal hernias that we mentioned a little earlier. And plus we have a prostate gland, so therefore if we wanted to distinguish this, if we didn't have any type of distinction there, we should be able to determine that this is indeed a male pelvis, just because we see a spermatic cord and we also see a prostate gland. So now you have the obturator internus muscle, sitting right there, and they call this the obturator internus muscle because it is at the inside, on the inside of the obturator foramen. And we have the rectum, and one thing that's important to picture is the fat planes that surround the rectum. Because if there is any type of disease process that involves the rectum, this fat plane is usually obliterated. So if you see the fat, that generally can give a good signal or indication that the rectum is not pathologic. But this triangle of fat that surrounds the rectum is a good indicator of the health or condition of the rectum. So first sign of inflammation, you see obliteration of that fat. So axial T2 weighted MRI of the female pelvis. In here, we don't see a spermatic cord anywhere. We don't see a prostate gland, and we see a vagina. So without any type of distinction, we should be able to distinguish that this is indeed a female pelvis. And you have the anus right there, and you still have this fat plane. So at the first sign of inflammation, you will see obliteration of the fat plane. You will see phlegma in the fat plane. You wouldn't be able to see a nice visualized fat plane. So the primary muscles of the pelvic diaphragm are the levator ani and the coccygeus muscle. The levator ani muscles are the largest and most important muscles of the pelvic floor. The two coccygeus muscles form the posterior portion of the pelvic floor. This can be found on page 510. It's important that you understand the pelvic diaphragm muscles. This image, I believe, is on page 513. There's a sagittal T2 weighted MRI of a male pelvis with urogenital diaphragm. And here you want to visualize the rectum. You see the colon leading down into the rectum, collapsed at this point, and anterior to the rectum, we know that this is the region of excuse me, I'm sorry. Region of the prostate and the prostatic urethra comes through here. So you have the bladder and you have the urethra, the orifice of the urethra. Then you have the prostatic urethra, the part of the urethra that's wrapped up in the prostate, and then you got the membranous urethra, followed by the penile urethra. So this is the actual beginning portions of the penis. So that's why this is called the penile urethra. Membranous urethra, prostatic urethra, pubic symphysis, rectum, anus, down in this region. Another thing that we should point out on this picture is the seminal vesicle. Seminal vesicle, this contraption right there, lays superior and anterior to the prostate. So in this sagittal image, the seminal vesicle is seen there. On an axial image, you will see the seminal vesicle flanking the prostate, like Mickey Mouse ears. Sagittal T2 weighted MRI of the female pelvis. Page 515. So here we want to clearly identify the uterus. 100% know the uterus, 100% know the bladder, 100% know the vagina. Clearly identify the rectum. The rectouterine pouch is also important to understand. The urethra is a very short urethra. I'm sorry, I mislabeled that, but that's coming down there. But that's the urethra, and the pubic symphysis, the bone. This is the bone. And the bladder sits right on top of the bone. And then you have the body of the uterus, which sits right over top of that. This area would be called the perineum. The perineum is the area located posterior to the symphysis, posterior to the pubic arches, and anterior to the coccyx. Okay, the region is divided into two triangles, posterior and anterior. The posterior triangle is the anal triangle, and the anterior triangle is the urogenital triangle, commonly referred to as the urogenital diaphragm. These muscles like to act together. That's why when you're relieving yourself in the bathroom, it's kind of hard to distinguish between one another, even though it is quite possible that you can contract part of the muscle without contracting the other. However, they like to operate together. In females, the perineal body is located between the vagina and the rectum, and in males, it is located between the rectum and root of the penis. So the bladder is a pyramid-shaped muscular organ that rests on the pelvic floor. In a normal adult, it takes approximately 200 to 250 milliliters of urine to accumulate before the urge to urinate is triggered. However, the bladder has a potential storage capacity of approximately 750 milliliters. So when you get the urge to relieve the bladder, it's about 200, 250 milliliters. So we have about 500 more if needed. That's when you hold in your urine. Now, the male urethra is much longer and extends than the female urethra, and extends from the inferior portion of the bladder. It can be subdivided into three regions: the prostatic urethra, the membranous urethra, and the penile urethra. The prostatic urethra is the prostate right there. So the prostatic urethra is that which travels through the prostate. And men with prostatic hypertrophy, where the prostate is huge, actually squeezes down on the ureter. Not the ureter, the urethra, and it's difficult for the male to void. After the prostatic urethra, we have the membranous urethra, and that's just a very, very small portion of the urethra right there until we get into the penile urethra. And this image is on 519. So this is a sagittal T2 weighted MRI of the male pelvis, and we want to clearly identify the sacrum as well as the coccyx. The prostate is important, the rectum is important, the urogenital diaphragm is important. Corpus cavernosum is part of the penis. The bladder is important. It's fluid filled. So in the T2 weighted image, it should show up bright. The corpus spongiosum is part of the penis. Then you have the penile urethra, the membranous urethra, because this is the prostate. So this little bit would be the membranous urethra, and then it would stop there, and then the penile urethra would come through there. Okay, this is an axial T2 weighted image of the female pelvis with the bladder. You can follow along on page 521. It's important. And in this image, you want to fully recognize the bladder, and look at the bladder, T2 weighted image, and look at the fat on the T2 weighted image. So we have the uterus, the ovary, which is clearly identified with the follicle. So we're looking at follicles that release the ovum. You can clearly identify the ovary here on the pelvis on the MRI. So the MRI is a very, very good study for female pelvic anatomy. You can see the ovary very well and assess it for pathology. So ultrasound isn't the only way to identify female pelvic anatomy. You have the rectum here. So we have the uterus, bladder, rectum. Rectum, bladder, rectum, uterus, bladder. Rectum, uterus, bladder. Corona T2 weighted MRI of male pelvis with the rectum. The rectum is the terminal part of the large intestine extending from S3 or sacral 3 to the tip of the coccyx. The upper third of the rectum, the rectal ampulla, has considerable distensibility. The anal canal is the distal portion of the rectum. The anus marks the exit of the anal canal. Here, right there, seminal vesicle. So we have here is the prostate, seminal vesicle, right there, seminal vesicle. And the seminal vesicle has leads down to the prostate by the way of the ejaculator duct, ejaculatory duct, and then from there it can lead into the wrong way, I'm sorry. A little happy with the buttons there, sorry. The ejaculatory duct and leads back into the penile urethra. So this image is on page 524, and here's an MRI image of the female pelvis with rectum. So you have that perirectal fat area, which the radiologist, which would aid in the interpretation of the study if it is without pathology. So you want to see it a healthy shade of gray when it comes to fat. Here you want to be able to point out the rectum, of course the levator ani muscle, and as you can see, this is the rectum, and the levator ani muscle right there, and the obturator internus, obturator externus muscle. Obturator externus, and then the obturator internus. So the obturator internus is internal, and the obturator externus is outside of the obturator foramina. Just the inside and outside. So if you're looking outside, it's the externus, inside is the internus. This image can be found on page 525. The uterus is a pear-shaped muscular organ located in the anterior portion of the pelvic cavity between the bladder and the rectum. The wall of the uterus is composed of 3 layers. The endometrium is the inner glandular tissue. The myometrium is the muscular layer, and the perimetrium is the outer layer, consisting of a serous membrane that covers the fundus and posterior surface of the uterus. T2 weighted MRI of the female pelvis with the body of the uterus. So we have the bladder, and we have, this is the uterine cavity, so this is the inside of the uterus. The body of the uterus is there. And they call in this dark triangle here the myometrium, or that muscular layer of the uterus. So 866, this image can be found on page 529. And here we have the uteral sacral ligament, a couple ligaments that hold the uterus in place, suspensory ligaments of the uterus. The uterus is stabilized by several pairs of suspensory ligaments formed by the peritoneum. The round ligament extend laterally from the uterine cornu to the inner inguinal ring. The uteral sacral ligament extends from the lateral walls of the cervix to the anterior surface of the sacrum. And the lateral cervical or cardinal ligament extends like a fan from the lateral walls of the cervix and the vagina and anchor into the fascia of the wall of the lesser pelvis. This is a coronal T2 weighted MRI of the female pelvis again, and here we was just speaking on the suspensory ligament of the ovary, which holds the ovary in place, the perimetrium, myometrium, and endometrium, the three layers of the uterus, the levator ani muscle, the urethra, bladder. I guess collapsed bladder is not full. But here are the ovaries. This is the left ovary. And the paired ovaries are small, almond-shaped organs located on either side of the uterus. The cord-like ovarian ligament attaches the inferior aspect of the ovaries to the lateral surface of the uterus. The suspensory ligament attaches the superior aspect of the ovaries to the lateral sides of the pelvic wall and contains the ovarian vessels. That's this ligament, the suspensory ligament of ovary, page 531 on the right side, the suspensory ligament. So this image can be found on page 531 as an axial T2 weighted image of the pelvis and ovary. So here you want to identify the uterus, of course. Should have no problems identifying the uterus, the bladder, and the ovary. Page 533, we're going over to page 533, axial T2 weighted MRI of the female pelvis with the vagina. And here, we're down in the lower levels, we have the greater trochanter there, greater trochanter, and we have the rectum, the vagina, and the bladder. So that's the order from posterior to anterior is the rectum, the vagina, and the bladder. Axial T2 weighted MRI of the female pelvis with the broad ligament. This image can be found on page 534. And here we can clearly identify the gluteus medius and maximus muscles, the iliopsoas and piriformis muscle. So you have the iliopsoas muscle, the iliacus and the psoas muscle converging, and the piriformis muscle. This is the gluteal group. So a peritoneal fold called the broad ligament encloses the ovaries, uterine tubes, and uterus. The broad ligament extends from the sides of the uterus to the walls and floor of the pelvis, preventing side-to-side movement of the uterus and dividing the pelvis into anterior and posterior pouches. The anterior vesicouterine pouch is located between the uterus and the posterior wall of the bladder, whereas the posterior rectouterine pouch, or the pouch of Douglas, lies between the uterus and the rectum. The pelvic spaces are common areas for the accumulation of fluid within the pelvis. Another space in the pelvis is the retropubic space, which is located between the pubic bones and the bladder and contains extraperitoneal fat and connective tissue for the expansion of the bladder. So this is that retropubic space, because this is the pubic bone right there. Pubic bone, symphysis pubis, pubic bone. So this would be retropubic space. Sagittal view of the male pelvis. The principal structures of the male reproductive system are the testes, epididymis, vas deferens, and ejaculatory duct, seminal vesicles, prostate gland, bulbourethral gland, and penis. The scrotum is a musculotendinous pouch that encloses the testes, epididymis, and lower portions of the spermatic cord. The pair of testes suspend in the fleshy, pouch-like scrotal sacs. The epididymis is a tightly coiled tubular structure located on the superior posterior surface of each testy. So you have the testy, you have the epididymis, you have the vas deferens, which leads the prostate. I'm sorry, prostate right here. That's the seminal vesicle. Seminal vesicle. So the vas deferens, it travels up the vas deferens this way. The seminal vesicle secretes hormone. Contents from the vas deferens meet the seminal vesicle, goes through the prostate, which hormones are then added to the fluid, and then it travels down into the membranous urethra, into the penile urethra. This is the male reproductive system. So now that we had a brief review on that, we can look at sexual anatomy. This is a sagittal T2 weighted MRI of the male reproductive pelvis. And orientation, sacrum, rectum, still rectum. You have seminal vesicle. And here is your prostate. And from the prostate you have, this is the bladder, so the urethra is coming down through there, and the urethra will go through the prostate and travel through there. Membranous urethra, penile urethra, prostatic urethra. Coronal view of the male reproductive system, you see the spermatic cord, the vas deferens, the uniform plexus, testicular artery is all part of the spermatic cord. So you have the epididymis and the testes. So sectional anatomy. This image can be found on page 536, T1 weighted MRI of the male reproductive system. So again, ultrasound is not the only modality that can clearly visualize pelvic anatomy in the male suitable also. So we want to see the inguinal canal. See the inguinal canal coming down there with the spermatic cord inside of it, and it's traveling down to the scrotum, and here's the testis. Sagittal T1 weighted MRI of the pelvis with the testes. This image can be found on page 537, and here we see the rectum, we see the bladder, we see the prostate. So the seminal vesicle will be up in there. The bone, pubic symphysis, you have the penis, and you have the epididymis, so that would make these the testes. So you want to be familiar with all of this anatomy. T2 weighted MRI of male pelvis with the testes. You want to know all the anatomy here. The head of the epididymis, the median raphe, which should be there to separate the testes, and the scrotum is just the sac that holds the testes. These are the testes. 1, 2. So be familiar with all of the anatomy on this page. More sectional anatomy of the male pelvis with the spermatic cords. This is the spermatic cord. Remember, this is the path that the testes travel from infancy to maturity, as they sit on top of the kidneys initially, and they burrow their way down until they reach the scrotum. So this is the corpus cavernosum. This would actually, if you was looking at the penis in face, this is what it would be. You have the corpus cavernosum, and at the bottom you have the corpus spongiosum. So the corpus cavernosa consists of a network of collagen fibers and spaces that become enlarged when filled with blood, contributing to an erection. So this is on page 540, femoral artery. Important femoral artery, femoral vein. If you can remember navel and V E L. I'm so proud of myself, I'm sorry. So navel stands for nerve, artery, vein, empty space, lymph node. So if you remember that, and here it'd be backwards, so it'd be nerve, artery, vein, empty space, lymph node. The insertion of the rectus abdominis, the six-pack. As you can see, the rectus abdominis goes all the way down until we are in the femoral, the neck of the femur. So here we know that we're in a male pelvis because we have a spermatic cord, we have a rectum, and we have the prostate. So this is a T2 weight image of the seminal vesicles with the endorectal coil, which means this is of the rectum, and the reason why it's a perfect circle is because the magnetic coil is inserted into the rectum. Traumatic examination, of course, however, it yields great images of the pelvis. So the seminal vesicles are paired accessory glands consisting of coiled tubes that form two pouches lateral to the vas deferens on the posterior inferior surface of the bladder. So these two are the vas deferens right there. And here's the seminal vesicle. And there's the seminal vesicle. The prostate gland is the largest gland of the male reproductive system. It secretes a thin, slightly alkaline fluid that forms a portion of the seminal fluid. The verumontanum is a longitudinal mucosal fold that forms an elliptical segment of the prostatic urethra, marking the point where the ejaculatory ducts enter the urethra. We'll see that on pictures to come. Sagittal T2 weighted MRI of the prostate gland. This image right here can be found on page 543 if you are indeed following along in your textbooks. So here you want to be able to identify the seminal vesicle, the retropubic space, because it's the pubic bone, so the retropubic space. So male and females have retropubic space, and as well as the prostate. This is an illustration. The illustration of the zonal anatomy of the prostate gland. So the central zone is located at the base of the prostate between the peripheral and transition zones and accounts for approximately 25% of the glandular tissue. The peripheral zone is the larger of the zones, comprising approximately 70% of the glandular tissue. The transition zone forms only 5% of the glandular tissue. It consists of two small lobules that are located lateral to the proximal urethra. So you have the transition zone, the central zone, and the peripheral zone. All of this comprises the prostate gland. So now we attribute that information to sectional anatomy. This image can be found on page 546. And we see the prostate urethra. Prostatic urethra sitting right there in the middle of the prostate. And you can see the different zones. You see the peripheral zone. You see the central zone. again, be familiar with the anatomy on this slide 8-102. I'm just backtracking because I am not sure where I left off. Be familiar with the anatomy on this slide. This is, again, page 548, and this is page 549. We want to understand the gluteus maximus muscles that lay posterior and anus, of course. You want to be able to identify I guess the rectum, the penile urethra, spermacord, gluteus maximus, perirectal fat, the ischiopubic ramus. So we have the ischium back there, the pubic in front, same here, ischium in the posterior, pubic in the anterior. So the vasculature of the pelvis, extending from the dorsal wall of the aorta just above the aortic bifurcation at the level of the fourth lumbar vertebra, is the median or middle sacral artery. The descending aorta bifurcates into the left and right common iliac arteries. The smaller internal iliac artery extends posteromedially into the pelvis, just medial to the external iliac vein, and branches into an anterior trunk and a posterior trunk. The anterior trunk of the internal iliac artery supplies blood to the perineum. The external iliac artery becomes the femoral artery at approximately the level of the anterior superior iliac spine, or ASIS. Branches of the external iliac artery include the inferior epigastric artery. This artery is a recurrent artery that actually travels up the rectus abdominis, which supplies blood to the muscles and skin of the anterior abdominal wall and the deep circumflex iliac artery. And that's why when you see radiologists access the femoral vein, they have to access the femoral vein on or near the pubic bone so that they can supply pressure when trying to hold compression onto that vessel so it doesn't extravasate blood. One thing you don't want to do is you don't want to hold enough pressure there to occlude the epigastric artery, because it's in the region. Because if you occlude the epigastric artery, well, then you just cause an ischemic condition to the rectus abdominis muscle. It's important to know anatomy if accessing the femoral vessels. And for venous drainage of the pelvis follows a pattern similar to that of the arterial supply. Mainly the internal iliac veins and the tributaries drain the pelvis. So, if you study when you study the arteries of the pelvis, they have complementary veins. Of the same name. Complementary veins of the same name. The external iliac veins extensions of the femoral veins return blood from the legs. The common iliac vein arises posterior to the common iliac artery. So the vein is posterior to the artery. From the junction of the internal and external iliac veins, the inferior vena cava is formed at the level of L5, just a little to the right of midline. So this image can be found on page 553, and you want to be able to identify all the anatomy on 8-112. on this particular image, we want to be able to identify the rectus abdominis. The sartorius muscle is a long muscle, elongated muscle. It wraps around the leg. It's an important muscle to identify. It's right there. The iliopsoas muscle, the internal obturator, again, of course, the internal obturator is internal to the obturator. That's why it's named as such. The rectum, prostate, and the greater trochanter. Right there is the greater trochanter. Finally, we have to discuss the anterior view of the lymph nodes, the lymphatic system, and the pelvis. We know what the lymphatic system is by definition. Pelvic lymph nodes include nodal chains or groups that accompany their corresponding vessels. Those nodal groups that correspond to pelvic vessels include the common iliac, internal iliac, external iliac, and sacral nodal groups. So the arteries and veins are named similar to the lymphatic nodal chains. So if you understand the name of the artery, you should be able to understand the name of the vein and also understand the name of the lymph nodes in the region. So on this picture, which is pretty much adipose tissue, this is showing with very much detail the inguinal lymph nodes. Inguinal lymph nodes. This is that sartorius muscle that wraps down the leg and attaching into the lower leg. The sartorius muscle, I believe it is the longest muscle. The psoas muscle is long, reaching from the lumbar, attaching into the femur, but the sartorius muscle is long also, attaching to the top of the ilium and reaching down into the lower leg. So here we have an axial T1 weighted MRI of the right hip with the femoral vessel and inguinal lymph nodes. The inguinal lymph node drain lymph from the lower limb, perineum, anterior abdominal wall, as far superiorly as the umbilicus, gluteal region, and parts of the anal canal. Pelvic lymph nodes are considered pathologically enlarged when they exceed 10 millimeters or 1 centimeter in the short axis. So when you are measuring lymph nodes, you don't measure them in the long axis, you measure them in the short axis. And when they have reached 1 centimeter or 10 millimeters, then they are cause for concern. This has been the module for the pelvis.